Can you hear me, Pankaj?
Yes, I can hear you. Can you hear me, doctor?
Yes, yes, I can hear you.
Okay, all right. So, namaste and good evening to all of you from India. My name is Pankaj Savadekar, your host, and I am a brand representative from Medical Tours India. And we have Dr. Satyaranjan Das with us. He's a director hematology and hemato-oncology and bone marrow transplants at JP Hospital, a very renowned hospital institution, medical institution in New Delhi, India. Okay. Actually, we were supposed to have uh, two doctors from HCG Cancer Hospital, but due to certain scenarios, they had to cancel the show. Probably they had some surgery, a last minute one, and they had to cancel the show. But and we requested Dr. Satyaranjan Das, and as usual, he was very kind enough to cooperate and join the event for us. So Dr. Satyaranjan Das comes with a great amount of experience. First of all, comes with a military background, has more than 20 years of experience, has been a part of peace forces. So just imagine, he hasn't just done surgeries in the the usual safe zones like India, but then he has also been out of the country and conducted surgeries in those kind of atmospheres over there, you know. So have really great respect for Dr. Satyaranjan Das, and whatever number of patients that we have sent to JP Hospital to treat under him, he has been a great help. So not taking much of your time, I want to uh, I want to request Dr. Satyaranjan Das to take it on from here. Thank you, and I'm very sure we are going to have a great show today. Thank you. Dr.
Thank you.
Satyaranjan Das, over to you.
Thank you, Mr. Pankaj, for telling all those good words. Yeah, a bit from myself. I am ex-military doctor, and I have been a hematologist in armed forces also, and now I am working in JP Hospital as a hematology, hemato-oncology, and BMT director. So today the topic is sickle cell disease, and we will be giving an overview, then of course causes and treatments, how sickle cell happens, what are the problems, then of course how we can treat it and how we can get rid of this disease particularly. So coming to the second slide. Why the slide is not moving, Mr. Pankaj, can you check it? Okay. Okay. Hello, Mr. Pankaj, you are there?
I'm there. I can
Any
see the slides, sir. I can see
okay,
the
but
slide.
it took some
Yes.
time for changing, that's why. Anyway,
Okay.
so
Okay.
let us look at the prevalence of sickle cell gene in the world. If you look at this is the world map, the maximum density that is around 10,000 to 1 lakh per country is India and some of the African countries. And then comes the next density, which is in some more African countries, and of course the America and the Latin America. You can see it. So if you see, there is a picture also in the right. This is also the map of this continent, that is Asia and Africa. If you see, there is a green stripe and there is a yellow stripe. You see, this is the Mediterranean where this sickle cell disease has started and spread across the Asia and Southeast Asia, and India comes on that. The other one is that African countries. Why I am showing this picture here? Because the sickle cell varies in their intensity and manifestation, which I'll come to it later on. This is what the Mediterranean type of sickle cell, which prevalent in India, and this is the where the sickle cell has originated and gone, of course, to the American and Latin America. So they are the same types of sickle cell, which are little severe then what sickle cell exists in this belt, that is the Mediterranean countries, Southeast Asia, and of course India. Coming to what it is an inherited gene disorder. That means the parents has to carry the gene and it has to be given to the child. So it is not automatically happens in a child. So this gene has to be inherited from the parents. It affects the shape of the red blood cells which carry oxygen. We all know that red blood cell carries oxygen from the lungs to the various parts of the body through the blood vessels. In sickle cell disease, these red cells, they deform, they become like sickle shaped or crescent moon shaped, and they become rigid and sticky, which sticks to each other and stops the flow. That is how sickle cell makes the problem. If I tell it is inherited, means it is taken from the parents, then how it is inherited? The medical terminology used is autosomal recessive pattern of inheritance. What it means, and this is that the parents, both the parents has to be half affected. That either half or one parent or both the parents may be fully affected, but at least one copy of the affected gene has to be present in the both the parents so that the child becomes a sickle cell disease. You see, this is how the transmission takes place. If both the parents are half affected, there is a chance that one child out of 4 will be fully affected, that is SS, and 2 will be half again like trait, what we call it half affected means trait, and 1 still may be normal because you will carry the normal gene from both the parents. The mutation which happens, it happens in the hemoglobin B beta gene, which is found in the chromosome 11, and the mutation causes a single amino acid substitution of the valine for glutamic acid in the beta chain. That is what the abnormal hemoglobin is formed. Because I am talking to doctors as well as patients, I have to speak little bit of medical terminology and about little bit of pathophysiology, and also I'll come down little bit in the layman term so that the patients, those who are also listening, can understand. Now, why this sickling takes place? Okay, there is some bad hemoglobin, but normal hemoglobin enables red cells to flow with the oxygen in the blood vessels, and the abnormal hemoglobin, that is the sickle hemoglobin, is not so soluble like normal hemoglobin. That is why they are rigid, they clumps to each other and they blocks the blood vessels. That is why the sickle cell causes the problem. And what all problems and how it causes? You see, traditional theory, we know that in a normal blood vessel, these are RBC, these are flows very nicely, there is no block or anything. In a sickle cell, we know that these RBC sickle and clumps to each other, and that is what blocks. But it is not the only thing that happens in sickle cell. When this crescent form or sickle form of RBC takes place, that of course remains the major cause of problem. However, there are additional things happens that we say the cellular action, the surface action, all those things that causes such kind of a block. These are the new research which gives rise to this theory that in addition to sickling stick to each other, there is endothelial activation. Endothelial means the inner lining of the blood vessel. They also activate. Their enhanced adhesion means these cells stick to each other more and also stick to the wall of the vessel. Neutrophil activation. There are these kind of cells, those are known as neutrophil. They also become more active. Polymerization of the hemoglobin takes place and some of the hemoglobin breaks down. This breaking down also increases the chance of adhesion to each other. So coming to basic, more than only sickling, the other things which takes place, endothelial activation, enhanced adhesion, neutrophil activation, polymerization, and chronic hemolysis. All those things give rise to what is the main problem in sickle cell disease is vaso-occlusion. Now we say sickle cell disease and sickle cell trait. If those are what happens in sickle cell disease, then what is sickle cell trait? When a child is born with one defective gene, the other gene is all right. That is known as sickle cell trait. And these sickle cell traits are generally well, but they may still have few sickle cell, like in this blood smear you can see one or sickle cell you can still see in the blood smear. They generally don't suffer, they are the carriers. But in extreme conditions, if they go to high altitude or other things where oxygen is less, or there's extreme cold temperature, they may also suffer, but they are less likely to suffer. They are known as sickle cell trait. And to have a sickle cell disease, at least both the parents has to be sickle cell trait. And now you just see the sickle cell disease, they will always have problem in comparison to sickle cell trait, which the parents are. The child, if he is sickle cell disease, he will have so much of sickling in his peripheral smear, if you can see it, and they will have invariable problem. All of them will suffer from one or the other. The most important thing in sickle cell you have to understand that phenotype variation. Many patients comes to us, they say, you see, my neighbor's child is also sickle cell disease. He doesn't suffer much, but my child suffers because this variation takes place. I was showing you there basically there is a ethnicity variation also. One which has started from the Mediterranean and has come to the Southeast Asia, then Asia, India and all. They are little less problematic than the one which has started from African countries and gone to United States and Latin America. So ethnicity varies. Type and frequency of mutation also varies. In the sense, there are some who have got a very frequent mutation in the cells. That is why they suffer more and the others may suffer less. Geographical variation. Sorry, as I was telling, that there are certain countries there the sickle cell disease suffers less than in some countries where sickle cell suffers more. In some of the sickle cell, there will be high HbF level. They also will suffer less. So there is a very significant phenotypic variation among the patient also. Now, what are the problems with sickle cell one has to understand, because as few of my patients are also listening, that there will be major problem like anemia. This child has got anemia. Pain is the major factor. If we say that, we call it a vaso-occlusive crisis. Many a times there will be pain here and there. Swelling of the foot, hands and feet. You can see this picture. Leg ulcer, very frequently there will be ulceration. We call it hand-foot syndrome. Frequent infection. I will come to it later on also. They will have frequent infection. Delayed growth. There will be vision issues, means they may not see. There will be retinal problem and chronic kidney disease. These are the major problem which happens with sickle cell disease. So why all those things happen? Because the painful vaso-occlusive crisis means there is occlusion in the blood vessels, depriving that part of the body to get good oxygen. And that is the clinical hallmark of sickle cell disease. They are much in number, and always a sickle cell disease is admitted to the hospital with a problem, that is vaso-occlusive problem. These events leads to ischemia, tissue damage to that particular area, and there is experience of huge pain. Then that leads to the severe pain and inflammation in a particular area or extremities, and then they become inflammation, and the subsequent chronic problem starts from there. But you have to see one thing, that these vaso-occlusive crises are tip of the iceberg. Means many a times vaso-occlusion going on inside the body which are not so painful. The patient may not understand. Of course, there will be some vaso-occlusive crises which will be painful. They are bigger ones. But all the while in a sickle cell disease, some kind of vaso-occlusion is going on inside. And that is going to give rise to long-term problems in comparison to the vaso-occlusive crises which are seen, visible because of pain. They are treated. But those who are vaso-occlusive crises which are happening without pain, they are untreated. And these vaso-occlusive crises gives rise to complication in sickle cell disease. There are various complications. These vaso-occlusive crises, pain can always be managed with painkiller on that. But what comes out of these are these all things: stroke, acute chest syndrome, pulmonary hypertension, chronic pain, leg ulcer, nephropathy, liver failure, heart disease, splenic sequestration, infection, arthropathy, all those things. I'll come few of this in details in the next slide. But these are the problem which makes the sickle cell disease is a very problematic disease. So what are these complications? I'll just touch upon few of these complications in a little bit in detail. This is the vaso-occlusive crisis or pain crisis, which I was talking to you. These are because of occlusion. Sudden onset of pain will be there. Pain can be sharp and sometimes you feel like stabbing. This may affect any part of the body, leg, abdomen, any part of the body can affect it. So these are the hallmark of the sickle cell disease. And another one problem which takes place is stroke. Many a times the young sickle cell, they will have stroke in the brain, that is depriving a part of the brain with the oxygen, and that leads to damage of that particular part of the brain, and that may come as severe headache, seizure, that means fits, sudden weakness or paralysis of a particular body, change in environment. Sometimes the child will just be dull and trouble in speaking, may not speak, trouble in seeing visual, and you will not be able to walk. So you have to understand, you have to recognize that there is a stroke, immediate action needs to be taken. Then other complication is acute chest syndrome. We all are aware of this. Sickle cell disease will have lung infection and there will be breathing issues. And this can complicate with pneumonia and other things. Pulmonary hypertension, though it happens only in adulthood, but this affects badly and a patient can have lungs problem, breathing problem, oxygen problem. Other part of the body like including kidneys, including liver, they all can get damaged because oxygen is not reaching. Splenic sequestration, this is a life-threatening and many a times it is fatal. You can see visibly the spleen becomes visible, the abdomen swells up and it is severe pain in the left side of the abdomen, and this child's anger spleen can be visible. This is life-threatening and it requires immediate blood transfusion to relieve it. If it is not done immediately, and it invariably becomes fatal. Blindness, as I was telling, that sickle cell can affect the vessel of the eye and cause blindness. Leg ulcers, I have already shown you. Gallstones, because of the cell breaks and a pigment known as bilirubin comes, and that can be deposited in the in the gallbladder, and it can cause gallstones. Priapism, again it happens in the adulthood. It is very painful. The penile vessels are blocked and the penis remains erected for a long and gives a severe pain. Deep vein thrombosis again is a common problem in sickle cell disease. Those sickle cell disease patients, those who are becoming mother, they will have a lot of problems during the pregnancy, including anemia. They can have miscarriage and premature birth, all those things. One more important, though it is not very common, but we call it aplastic crisis. Mean there will be severe anemia, red cell production will be stopped, and this is caused by parvovirus infection. Again, this requires transfusion. So these are the main complications which happens in sickle cell. So whether it's patient's view or from the doctor's view, that we have to recognize these complications and needs to tackle these complications early. So the diagnosis part is very simple. Very simple. When you suspect somebody has got this kind of problem, you want to do a simple blood test that is known as HB variant analysis by high HPLC, or even you can do a HB electrophoresis. That will give rise to the diagnosis. If you see in the variant analysis, HbS is 84.8%. You see the peak, very big peak, and this is sickle cell disease. Here you see there is a HbS which is only 21% and around 74% normal hemoglobin. This is a trait. What I was telling you, that is half. And we all know the mutation analysis can be done in the chromosome 11. The sickle cell gene is there, that will be mutated. Even nowadays, a mutation analysis can be done. If you don't get a blood sample, only a tissue sample, you can do this. Okay, how do we now? We know what are the problems. Now how we know that how we can diagnose it. Now then what to do if there is a sickle cell disease. As I told you, sickle cell trait generally don't pose any problems. They are easy to manage. Sometimes of course they can have some issues, but generally not. They live like a normal person. Then who are the problematic is sickle cell disease. So how do we manage the sickle cell disease? There are curative, means you need to cure the disease, then a allogenic HSCT, that is hematopoietic stem cell transplantation, which we commonly call it BMT, has to be done, or gene therapy. I will come to it later on. Then of course supportive management, that is day-to-day management. This is aimed at avoiding pain episodes or relieving the pains and symptoms and preventing complications. How the supportive management is done? Maybe medication and blood transfusion. I will come to it later. So let us come to blood transfusion first. Blood transfusion remains an important therapeutic intervention in patients with sickle cell disease. I don't have to overemphasize it. All of us will know. This aiming to both increase the oxygen carrying capacity of the blood and also to reduce the complication of the vaso-occlusion. How it reduces the complication of vaso-occlusion? Because when a normal individual's blood goes inside, which does not have sickle hemoglobin, they interface between the sickle hemoglobin cells and they can relieve the occlusion, and that is how blood transfusion helps. But no treatment is without any adverse effect. When we give blood transfusion, it is indicated in acute chest syndromes, transient aplastic crisis. If there is anemia, means HB is more than less than 8 or 9. Acute splenic sequestration, I will telling you, that requires immediate transfusion. And if that sickle cell individual is going for any procedure, then you have to give. Then long-term condition which takes the patient to take routine transfusion is a stroke. If somebody has got stroke, you cannot afford to have another stroke, and that will cause the person to be disabled. So you need to give in between transfusion. Abnormal transcranial Doppler, that is if you find that there is some occlusion in the brain vessel which may cause another stroke, so you have to give. And if there is multi-organ failure. But then what are the side effects of this? There are short-term side effects, means when you give blood, there can be overload, acute non-hemolytic reaction, or even sometime other reaction can take place. And that long-term reaction are that alloimmunization takes place. The more and more transfusion you give, there will be a transfusion reactions, iron overload, and the most important in many of the countries still remains the viral infection. So the viral infection, again, like hepatitis C, hepatitis B, all those can produce long-term complication. Basically, in sickle cell, we need to know that aim of the transfusion is to increase oxygen carrying capacity, restore blood volume, and prevent a vaso-occlusive crisis, or prevent the pain and reduce the sickle erythropoiesis so that there is less problem. Now comes to medication. First medication, I like to talk hydroxyurea. This has changed the management of sickle cell disease. And earlier, many of the patients used to suffer quite a lot, but they get a great relief with hydroxyurea. What hydroxyurea does? It induces production of hemoglobin F, thus reducing the hemoglobin S polymerization. So that if you give hydroxyurea, F increases. Those who have got increased F, they suffer less. Reduces neutrophil and reticulocyte count. As I was showing you that neutrophils and reticulocytes causes the adhesion. So if they are reduced, then the adhesion is less, blockage is less. Decrease neutrophil and reticulocyte adhesiveness and reduces RBC hemolysis. These all cause the decreased vaso-occlusive crisis. The lower annual rate of the vaso-occlusive crisis if you start a patient on hydroxyurea. Longer median time to the first crisis, means if you start in a child, the first vaso-occlusive crisis takes much late. It will not stop completely, but it will decrease it. And you don't have to give maximal tolerable dose. We generally start with 15 milligram per kg, and that does the job. And it is excellent drug to be used in hydroxyurea, to be used in sickle cell disease, and it helps quite a lot. Next comes cranlizumab. This is a new drug, relatively new, is from Novartis. It's an excellent drug. It reduces the pain crisis, and it has to be given intravenous, and it's given every 25 to 30 days. And the side effects can include nausea, joint pain. but this is very costly. This availability may not be everywhere. We had now just getting the experience of using this. It's giving a great relief. However, it is not a cure. It is sometimes it relieves the pain, decreases the pain episodes. Again, it doesn't stop the pain episodes completely. It decreases the pain episodes. It's an excellent drug to be used in sickle cell disease. Vexolator, this drug I have not used it, but this is supposed to be an oral drug, and this improves the blood flow throughout the body, and this is orally administered every day, and it modifies the underlying disease. Again, it does not cure the disease, but yes, it again decreases the vaso-occlusive episodes. L-glutamine is an oral powder, is available. This is FDA approved. Its action is basically antioxidant activity, and it reduces again the potential vaso-occlusive crisis. But again, it doesn't cure it. These are all costly managements. So it sometimes may not be available. So these medications can be done, but we have to see that a curative option. So but before going to curative option, let me first touch upon the management of vaso-occlusive crisis. It is the classical teaching when we were teachers or we were students. This used to be the classical teaching. You have to take these 5 steps when some sickle cell disease comes in pain or vaso-occlusive crisis. You need to administer oxygen. Even sometimes somebody says, no, his saturation is 96%. Why you are administering oxygen? No, here whatever red cells are deoxygenated, they have become sickle. We cannot allow any further red cells to be deoxygenated. So we need to give oxygen even if the saturation is good. He is not having breathing issues, but he is in pain. He has got a vaso-occlusive crisis. We need to give oxygen. How much we give? Usually we give 5 liters per minute. The second most important, or the most important rather, I'll say, is analgesia. And what kind of analgesia? Because the patient is writhing in pain, patient has got severe pain, so mostly we use opioid anesthesia. That is morphine, tramadol, and pethidine, all those drugs. In various countries, in various hospitals, the protocol is different, but morphine drug. But that we can use also non-steroidal anti-inflammatory drugs. These are the painkillers also can be used, but they are less effective, but they can be additive. We can use those. That we cannot use non-steroidal anti-inflammatory drug. It is not there. We can use it. Then third main thing is hydration. Because of dehydration, many a times this vaso-occlusive crisis takes place. So you need to give hydration so that your blood, if it is hyper viscous, it comes down. So we give IV fluid. How much IV fluid you need to give? 3 liters per meter square of body surface area. So you have to really give good IV fluid. And transfusion. Blood transfusion, I told you that blood transfusion helps in decreasing the vaso-occlusive crisis. So transfusion needs to give it. One drug known as pentoxifylline. This basically makes the RBC more malleable. In our country, we use it. Many countries may not be available. These are used in strokes, but this is a very cheap drug. One can use it and it may be beneficial. These are the 5 things you can do if a patient comes with vaso-occlusive crisis. Yes, before coming to the management, I should have talked prevention of vaso-occlusive crisis. How you can prevent? That is, all these drugs I told you, crazilizumab, then your hydroxyurea, those are the drugs to prevent. But there are certain other things also which can prevent vaso-occlusive crisis. A sickle cell disease, adults and even children should have good hydration, especially during exercise. If they are going in during hot seasons, there could be decrease in hydration. As I was telling you, hydration is one of the treatment. Here to prevent crisis also, one needs to drink large amount of water. A sickle cell disease should carry always a bottle of water with him. Adequate sleep. Sleep deprivation causes a lot of problems in the body. And one of them is there are lot, you see the pathophysiology of vaso-occlusive crisis is still being researched. So inadequate sleep, all can cause initiate a vaso-occlusive crisis. Temperature management, including avoidance of extreme cold. This is a very, very important thing. As I was talking, even sometime sickle cell trait also, if they go to a high altitude or very extreme cold temperature, they can have crisis there. So it is not that sickle cell trait doesn't suffer, but if they go to extreme temperature and get severely dehydrated, they can have. So it is very important for a sickle cell disease patient to manage the temperature well. They should not be in extreme cold or even extreme hot. Extreme hot causes dehydration, and that can do. Of course, very important thing is avoidance of emotional stress and strain. Many a times we have seen, particularly adolescents and adults with the emotional stress and strain, they get vaso-occlusive crisis. Now, again, one very important factor is the infection. Infection remains the most common precipitate for vaso-occlusive crisis. So how infection causes a vaso-occlusive crisis? As I was talking about the pathophysiology, leukocytes play a vital role in vaso-occlusive crisis. And we all know that if there is a infection, there will be increased leukocytes, that they cause this vaso-occlusive crisis. So infection directly can cause vaso-occlusive crisis in the particular area where there is infection, or in general also. So infection is one of the predisposing factor for sickle cell pain crisis. That is why infection needs to be avoided. Next is there are indirect effect of the infection which can cause vaso-occlusive crisis. The fever, if a patient has got infection, he will have fever, and that will cause water loss in the form of sweating, sometimes diarrhea, there will be water loss. So these kind of things will give rise to dehydration. As I was talking, dehydration will increase a vaso-occlusive crisis. And because the sickle cell disease, already there is a renal compromise or a kidney compromise, and with all those infections, their kidney cannot take out the blood, fluid, and there will be hyperosmolarity, and they all can indirectly cause. So infection remains one of the major precipitant factor for vaso-occlusive crisis. So infection we have to treat. If a sickle cell disease has got infection, that's need to be treated. But the most important thing in a sickle cell disease is how do you prevent infection? So we give prophylaxis, that is penicillin prophylaxis, because they are more prone of gram-positive infection. So penicillin prophylaxis is given from even childhood. From the age of 2 months, you can give penicillin prophylaxis to the adulthood, and that at least decreases the chances of gram-positive infection and makes less number of vaso-occlusive crisis. Vaccination is very, very important. In 1998, American Academy of Pediatrics took out that there was a 50% reduction of painful crisis after all those sickle cell disease were given pneumococcal vaccine. So such a important happening which happened, that prevention of infection by giving vaccine was reducing the painful crisis in those children to 50%. Sorry, all the childhood vaccination needs to be given. That includes pneumococcal vaccine, that is pneumococcal conjugate vaccine, typhoid vaccine, influenza vaccine, and H influenza B vaccine. These all are there in most of the countries' routine vaccination schedule. All needs to be given. Adult, again, all the sickle cell and including the sickle cell trait should take adult vaccines, particularly against the pneumococcal vaccine. That is very important. And vaccine against all capsular organism, because I was just missing here that all the sickle cell disease will lose their splenic function, because there will be autosplenectomy. Automatically their spleen will get destroyed by the age of 15 or 20 years of age. So there needs to be given all vaccines which prevents the infection against the capsular organism. This is the schedule. I just got one schedule. This is the schedule of vaccination. I don't have to go into the detail. Pneumococcus, meningococcus, H influenza B, and influenza. This is the virus influenza. All those vaccination needs to be given for both children as well as adults. So now coming to the curative treatment. Bone marrow transplant is curative, and as we know that patient selection is very important in bone marrow transplant. How do you select the patient? The patient has to have no organ dysfunction, because as you know transplant is a very difficult mode of treatment. If there is organ dysfunction, there will be problem, and the patient has to be relatively young so that the organs can take the brunt of the transplant, and they have to have a HLA match donor, whether in family or outside. Of course, we are doing haplo transplant, means half match family donor transplant, but the outcome, the overall, has to be slightly lower than the full match transplant. So one has to know that there has to be HLA match donor, the patient has to have all the organs intact. So it may not be always possible for all the patient, but yes, majority can undergo this curative treatment. But one has to keep in mind there are complications. Complication in form of infection during the transplant. Then whatever the drugs has to be given, it has got their own toxicity. Those all can come, and other complication can take place during the transplant. But today we are using the modern technology, the latest equipment, latest monitoring, so the transplant complication has come to minimal. Post transplant care again is very important for the people from the other countries. Those who come to us for transplant, they want to go away quickly, and they get into complication there because the monitoring is not proper. You have to monitor infection, you have to monitor your immunosuppression, then post transplant vaccination has to be given. All those post transplant care has to be done. Of course, while doing transplant, one need not forget there are long-term complications in the outcome also. Some percentage of the patients may lose their fertility. Some of them may have endocrine complication, and some may have the long-term complication. But these percentages are very low. When you are looking for a curative treatment, some of the complication, some of the long-term outcomes has to be taken along with it. Next curative therapy is gene therapy, which is still not available to everybody. It is still in the experimental level. So I will not go into detail about this. This gene is gene addition therapy, which is done by manufacturing a cell where there is a non-sickling globin gene, and through a viral vector it has to be put into the stem cell of the patient. This produces the native hemoglobin S as well as a normal hemoglobin, the resulting in decreasing the hemoglobin S and keeping the patient symptoms free. These are the methods how we do this. This is very expensive at the moment and also experimental. This is commonly not available in most of the countries. Now a bit about prenatal diagnosis. I think I just will take 1 to 2 minutes so that I can answer your questions. You see, it is very important that all couple, those who are both sickle cell trait or sickle cell disease, they need to know that they can diagnose a baby before the baby is born by doing a CVS sampling or amniotic fluid sample. If both parents have sickle cell anemia, particularly from the African countries, because they are the bad sickle cell anemia, the child suffers a quite lot, they should ask their doctor about this screening in their baby who is, or the fetus who is there in womb. It can be done if they are suffering from the sickle cell disease, which a 25% chance that baby can be aborted. If they are either trait or normal, that pregnancy can be continued. So with this, I'll stop here. Thank you very much. If there is any question, I am ready to take it. Pankaj, I am just over. If there is any question, if you can moderate it. Okay, I am just. Hello, Pankaj, can you hear me?
Can you hear me now? Hello, doctor. Can you hear me?
Yeah, yes, I can hear you.
Okay, okay. I think there was some network problem due to which, uh, there was some interruption, but Doctor, thanks a lot for detailed overview of
Was there
sickle
any
cell disease.
was there any network problem in between? I didn't see. I
No, there was no network problem from your end. I think my network
Yeah, your
interrupted.
voice is resounding little bit. Maybe you are in a less connectivity zone. Okay. Yeah.
Okay. Um, can you hear me now properly?
Yes, 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 yes.
Okay. So there are a lot of questions, doctor, and let me go on to them immediately because a lot of people have asked their questions. So, say from Nigeria, she has asked. She's a mother to a child suffering from sickle cell disease, and her first question is, why is there bone pain in sickle cell patient? Why do they suffer bone pains?
You see, as I was talking, all organs of the body can have vaso-occlusion, and the vessel inside the bone are very narrow, and all the bones requires blood supply for their nutrition. If there is any occlusion of any of the vessels which supplying blood to that particular area of the bone, there will be severe pain. And sometimes, in addition to this, sometimes this part of the bone can die and make osteomyelitis, means infection. It is a common problem in sickle cell disease. The bone may get destroyed and the bone may get infected, and it requires a long term antibiotic. You see, I didn't go into detail. Common complications once they become adolescent is avascular necrosis of the both the femur heads. This is commonly seen in African sickle cell disease. Both the hip joints will become bad, because again these joints are very crucial joints, and the blood vessels has to supply these bones for oxygenation. And if the blood vessel blocks, and that part of the bone destroys over a period of time, repeated pain, repeated infection means the death of the bone cells, and it gets completely destroyed. So many of these sickle cell patients require hip replacement once their hip joint is bad. Other areas, if there is osteomyelitis, you need to treat these with antibiotics. Again, bone is part of the body. As I was telling, bone pains are common in sickle cell disease. I hope she understood this.
Okay, thank you. Uh, you were saying that vascular necrosis of the femoral head is common in Africa. Is it because of the genesis there, or
No,
is there some other?
no. As if you are remember, I gave two types of disease in the world, that is sickle cell disease. Phenotypically they vary. That is the Asian, or which comes, the origin comes from the Mediterranean. That is they suffer less. If you see an Indian sickler, he suffers much less than what is African sickler suffers, because the mutation varies, the type of disease varies. This is the ethnic difference. And in India also it happens very rarely, but African sickle cell will suffer it more often, because they suffer more vaso-occlusive crisis than the Indian patients. And as I was telling, this disease has originated from the area where there was malaria predominant, and we all think, it is just hypothesis, that this was a protective mechanism which is created by the god to prevent malaria, because our sickle cell trait are relatively resistant against malaria. But now, if the two traits, this gene mutation which has taken place over millions of years, now causes problem for us. So it is basically the African origin of sickle cell disease is severe, more severe than the Asian and the European ones. That's why they suffer more from these kind of vaso-occlusive crisis, and particularly the avascular necrosis of the head of the femur.
Thank you, thank you. And okay, the next question from say again, why are sickle cell patients prone to splenic sequestration crisis?
Yes, I think I gave a little bit about this. This is again is one of the vaso-occlusive crisis. Where the vaso-occlusion takes place or the vessel occlusion takes place, it takes place inside the spleen. And spleen is one of the most vascular organ in our body. We say that all the blood cells are supposed to, when they are old enough, they are supposed to die, they go and die in the spleen. So all the cells, blood cells has to pass through the spleen. And spleen is such an organ, it's a lymphoid organ, it's one of the organ which is there. So, and it is very vascular. So once there is a block takes place in them, then the return of the blood doesn't come. That is how there is a immediate increase in the size of the spleen, and it is like somebody is pushing air into a balloon, and how the balloon enlarges, the spleen, it happens like that. The blood goes inside and the blood is not coming back. It is not a very common problem. It is a relatively uncommon problem, but it is a fatal problem, means potentially dangerous and fatal. So immediately needs to given blood, so that the normal blood mixes with the patient's blood and the flow is re-established. The flow to the spleen, back and forward and backward flow is re-established. Then only a patient can survive. This is very, very problematic, and this can be fatal most of the time.
Okay, thank you. Uh, then Dr. Buzu has asked some questions, but you have already answered, like what are the sickle cell traits and the pathogenesis of sickle cell disease. You have already answered that. You have also answered, is bone marrow transplant an only solution? No, it is, like there are other cures as well. Okay. But now two questions from Dr. Buzu, Nigeria again. He has asked these questions. Is bone marrow transplant a permanent solution?
Yes, to give answer shortly, yes, it is a permanent solution, because in bone marrow transplant, a healthy stem cell is put into the body of the disease after killing all the disease stem cells. So the healthy stem cell is a permanent, cure. However, we have to understand that with the bone marrow transplant comes some problem which are new to that patient, means graft versus host disease. Sometimes the cells, the donor cells may fight with the body of the recipient. That's known as graft versus host disease. So yeah, a new problem may come, but the original, if it is a successful bone marrow transplant, then it is completely curable and is a permanent curable. And what I told, there are certain complications associated with it, and graft versus host disease is one of them. And during the transplant, there can be infection, there can be regime related toxicity, that's the toxicity from the drugs which we give to kill the native stem cells. All those issues are there, but yeah, once it is successful, it is completely cured.
Okay. And what is the success rate of bone marrow transplants?
Yes, again, the success rate of bone marrow transplant varies. How it varies? A young patient with a full match donor from the family, the transplant success rate can be 95 plus. But if a patient is old, he has got already some partial damage or damage of the organs, here the complication may take place. The success rate may not be as good as that. Here, if a patient is more than 15 years old, he has already got some liver issues, some kidney issues. During the transplant, there can be problems, complications. Here, the success rate may not be 90%, it may be 80%. And in half match transplant, because there are issues like graft versus host disease, graft rejections, because it is half match, again the success rate will not be that high. The success rate may come down to 70% or 80%. Because of these issues, the success varies from something like 70% to 90-95%, depending upon the patient, who is going, who is the donor, and of course many a times the center should be good to tackle all the complication. Otherwise, if somebody is doing a transplant in a center where there is less expertise to handle the complications, then there will be problem. Otherwise, the success rate in sickle cell disease is good.
Okay. What is the ideal age? Generally speaking, what is the ideal age or the best age to do the treatments or the bone marrow transplants on children suffering
Okay.
from sickle disease?
Yeah, this is a not many people that think differently in these issues, but I always say that there are two things. One, the patient has to be little cooperative. For that, the age 1 year, the child doesn't understand anything, and child is not going to have that cooperation. Of course, the mother helps it out. We do also transplant, but I say more than 2 years, up to 5, 6, 7 years before any damage to any organ takes place. That's the ideal age. And if they have got a full match, that's the best time that a transplant can be done. You see, even we don't do transplant in sickle cell, thalassemia when they are more than 15, 16 years because there is iron overload and all those things. But in sickle cell, it is not that. We can do at any age, but you have to understand that if there is some organ damage or some other damage, and that can create a problem during the transplant. That is why that complication may go up if the age is high, if the organs are damaged. Otherwise, at any age, this transplant can be done.
But according to you, the base stage is between 2 to 6 years of
Two,
the
two to
age.
5, 6 years, 7 years. That's because when the child is absolutely all right before getting any major, organ damage, that's the best time to do a transplant. Even we can
Generally,
do it 1 year. We can do it 1 year. If there is a donor, there is no problem. But yes, there will be little issue. The child, handling the child during the transplant, the mother has to be there all the while. But yes, it can be done. We are doing 6-month-old child. If there is a HLH or something, 5, 6 month old child also undergoes a transplant. It is not that we cannot do it. We can do it. But yes, a little bit trouble. We have to handle the child well.
of course, of course. Now, this is my personal query. Like, uh, when is it that the organs generally start failing? Generally, I mean,
You see, you have to see this as I was talking regarding the phenotypically variations are there. In some sickle cell, the organ damage starts very early. They get very frequent vaso-occlusive crisis even from 2 to 3 months of age. So one
oh
had
my
to
God.
understand, yes, that some of them are very severe. The moment they are fetal hemoglobin, you see, naturally you have to understand that when a baby is born, they have got almost 95% fetal hemoglobin. All of us, when a baby is born, gradually over a period of 6 months to 8 months to 9 months, the fetal hemoglobin level comes down to 10%, 5% like that. And at the moment the fetal hemoglobin starts coming down in a sickle cell, they will start having vaso-occlusive problems. They can start as early as that. So it is, and but they are the severe ones, those who are phenotypically very severe. And generally, if in a family one patient suffers from quite early, the other also is likely to suffer. As in Indian sickle cell, if you see, till the times of 4 to 5 years, the child will not have a single, complaints. They start having one odd vaso-occlusive pain crisis from the year of 4 or 5. They are the milder variety, but they are sickle cell disease, but still they have not mild variety. Because in Indian sickle, if you do the HbF, all will have a higher HbF in comparison to those who are in United States or from Africa. They will have 2 to 3% HbF, whereas a Indian, if you do a HbF level, it can be 15%, 20% like that. So they suffer less. So you have to see, even in the African sickle cell also, individual to individual varies. Some of them, they will start suffering at 1 year of age, 8 months of age, whereas some will start the pain crisis around 3 to 4 years, 5 years like that.
Oh, got it. Uh, when the children go under ball, I mean, they do bone marrow transplants. Do they lead a normal life as an adult in future? Like, Can girls deliver babies without any hassles, or can males have a proper sexual life, a good normal life after they become adult?
Yeah, first thing I'll touch upon the normal sexual life. Both female and male after a successful transplant will lead a normal sexual life without any problem. But then I'll just put it here regarding the fertility. As I was talking about the long-term issues, there are certain drugs which is used during the transplant. They may affect the fertility both in male and female. Fertility means sperm count in male and ovulation in female. So you have to understand that there is a chance of around 10% of losing fertility when we are using high dose cyclophosphamide. Nowadays what we are doing is we are taking a different kind of conditioning, avoiding those drugs, avoiding radiation, so that these kind of long term complications should not arise. But cyclophosphamide becomes the one of the very good drugs of immunosuppression for bone marrow transplant, but we are using it in a lesser quantity so that in future we get very few numbers who will be losing their fertility. Otherwise most of them, you see, we are doing lot of transplant we have done in thalassemia. Many of them have become father, mother and everything. So it is it, but unfortunately one or will have this fertility issue, so that in the long term complication one has to count it, but that percentage is very low.
And can that infertility be treated in future?
Yes, it can be treated. If somebody's sperm count is low, that they can concentrate the sperm. If some, and many of them normally if their ovulation is not good in females, they can induce ovulation by giving medication. It becomes successful pregnancy in many of the cases, but still one odd, those who have no ovum at all, they may suffer infertility. But this percentage is very low.
Okay, thank you, doctor. I have some questions from Esther, who is a doctor from Nigeria. She has asked, what is the place of selenium, a micronutrient, in the management of patients with sickle cell anemia? Is this micronutrient helpful in checking oxidative stress? If yes, can it be recommended daily in low doses for patients with sickle cell?
See, I have not seen any study on this particularly micronutrient, but while presenting it, I showed you L-glutamine. It is also antioxidant. As an antioxidant, and as an antioxidant, it has been approved for use in sickle cell disease by FDA of USA. So many of the antioxidants can be used, but in various studies, it has not shown great benefit. That's why this generally not recommended. Many antioxidants are there, but this is one of the antioxidant which gets a mention because there has been studies where it is found to be beneficial. But again, these are marginal benefits. They don't give great benefits, these antioxidants.
Next question from her is, are there any specific diets, nutrients that can help patients reduce intervals of crisis? That's in a very sick patients and ACA patient generally.
See, there is no dieted recommendation. If you have remembered my slides, in one slide I have shown what are the how one can prevent vaso-occlusive crisis. There were four things: a good sleep and less stress, good hydration, and temperature. These are the four main things. Yes, diet is required for good nutrition. A good diet is definitely required for all the patients, but it may not have much effect on the vaso-occlusive crisis in sickle cell disease. But yes, hydration is one of the most important thing that all the sickle cell disease patient has to maintain the good hydration to prevent vaso-occlusive crisis.
Okay, and last two questions. One question is from Mr. Uporo. He is a father to a 2 year old girl suffering from sickle cell disease. Now, his questions are what's the best way to manage sickle cell condition in a 2 year old child to guarantee relative normal life? I think you have already answered this in a way. And what is the best treatment option for a 2 year old child with this, the same thing? So,
Okay.
is it the same answer that you gave before?
Now, I can just clarify a little bit more. A 2-year-old child, the curative will be bone marrow transplant. But if that is not happening for whatever reason, then the child needs to be vaccinated completely. The child has to be started on hydroxyurea, and the child has to be put on penicillin prophylaxis. And of course, good hydration always. That will keep the child, free from vaso-occlusive crisis during the time you are waiting for a curative option like bone marrow transplant.
Okay, okay. One more question has come from Esther. I have a patient with excruciating bone pain crisis that could not respond to cocodamol, pentazocine, and diclofenac. What other recommendations can be made for such a patient?
You see, as I was showing, the management of a severe pain crisis, whether there is oxygen good or bad, you need to start oxygen. You need to give a good hydration, and transfusion helps in them interposing normal RBC between the sickled RBC. And of course, painkiller you are already using. We generally use opioids and less non-steroidal anti-inflammatory drugs, but yes, you can choose whatever and use it. But during the bone pain crisis, these are the things needs to be done. Your pain has to be released, but hydration, oxygen, and transfusion will help reduce the pain here. And in future, whatever the bone areas are having problem, you need to do a imaging of those areas. Is there any infarct? Is there any osteomyelitis taking place? That also is a complication in sickle cell disease.
Okay, and this brings me to the last question of the session. What is allogenic bone marrow transplant, and how is that different than the external HLA-driven bone marrow transplant?
You see, bone marrow transplant in sickle cell disease is always allogenic. You see, autologous transplant is done only in certain diseases like lymphoma, myeloma, and autoimmune diseases. That's not done in sickle cell disease. Allo means somebody else donating the stem cell. Auto means the patient's own stem cell is infused after the chemotherapy. That happens only in myeloma, lymphoma, and autoimmune diseases. But for sickle cell, because his own stem cell is sickle, so we need to take a stem cell from a donor. When a stem cell from a donor it is taken, it is known as allogenic bone marrow transplant or allogenic hematopoietic stem cell transplant. So a transplant in sickle cell is always allogenic. I think the what he is asking is whether the
Or
allogenic donor is from the family or from the outside family. So if I
no,
have
no,
to
no.
tell,
The question is about. Sorry to interrupt you. The question is autologous. Like how successful are the autologous bone marrow transplants?
autologous bone marrow transplant is not at all done in sickle cell disease. I told it is only done in lymphoma, myeloma, and autoimmune disorders.
Okay, okay, okay. So it is always better to get a donor and to do
Yes,
the.
it the bone marrow transplant in sickle cell disease means it's from a donor. Either it is a family donor or a donor from the international HLA registry.
So can they check their HLA compatibility in their own country before coming over here?
Yes, if they can check if the patient's high resolution HLA has to be done, then that HLA has to be put in any of the registry, whether in their own country or any other country. They can check for the donor. Like basically, there are various registries in the world, like DKMS, this is a German-based registry. NMDP is a US-based registry. In India, there is Datri, and in there are registries in Singapore. So many other European has got many other European registries also there. So any of the registry today, they can search in all those registries in their own country also, and they can identify even a donor where the donor is available. If they can also search a donor in Datri in our country, Datri has got donors from India as well as outside. So donor can be from anywhere, but the registries are there. In those registries, the volunteers have given their sample and their HLA mapping has been done. So one has to search there. There is not, it is not country specific. They can search anywhere in the world.
Okay, okay. Basically, what I wanted to check was like before coming to India, if the patient is coming along with the donor, uh, whether their HLAs are fully matched or not, can it be checked or analyzed in their country, or it is based that they come over here and do the
No,
checkups?
what happens? See, if there is a match in the family, in the extended
Mhm.
family sometime, then the donor can come along with the patient. Otherwise, if you search in the registry, this registry will never tell you the name of the donor. They will just tell a registration number and there is a match along with so and so registration number. So they have to come with that match sheet, and from here we have to do rest of the work, so that the stem cell of the donor comes to us on that particular time of the transplant. No donor comes from the international registry to give stem cell here. You have to get the stem cell from the registry.
Okay, okay, all right.
That's the registry people. Suppose the donor is in California, they will harvest the donor in California, and with this same day flight, the stem cell will reach Delhi within 24 hours.
Okay, all right. Uh, there is one question in the chat. Sorry, two questions in the chat box. One question is, can a child whose parents are AA be born with SS as a result of random mutation?
As I told you, it is inherited. If both the parents are AA, the child cannot be SS. That means there is some issues, whether it is an adopted child or something like that. It cannot be if there is no spontaneous mutation. It is
Okay.
inherited.
And the,
There is no spontaneous mutation. Sometimes
okay,
hemophilia and all can have spontaneous mutation, but this particular disease there is no report of spontaneous mutation.
okay. And actually, the last question for the event is from Professor Yogun. Nice presentation, doctor. Hydroxyurea dose and for how long it can be taken?
We generally give 15 milligram per kg, sir. Thank you very much. We generally start with 15 milligram per kg and try to give a maximum tolerable dose where the TLC and platelet doesn't come so much, because we monitor the count every monthly sometime. And you see, you don't have to go even to the maximum tolerable dose. You can give even lesser than that, and 10 to 15 milligram is, children tolerate more than 15 milligram per kg even, but adults, if you give 15 milligram, that's more than enough. And hydroxyurea does a big benefit to the sickle cell disease. Till the time all those costly drugs are available to all of us, I think hydroxyurea remains the drug of choice.
Okay, okay. Uh, that is all. I mean, those were the all questions asked by the registered users. Thanks a lot, Doctor. This session was really heavy and a lot of information, and we really thank you. I call this is a blessing in disguise that The doctors from HCG had to cancel and you had to come on the show, but it's a blessing in disguise. Thanks a lot. Now, just a note for the viewers that whatever questions you may have for the doctor, you can send it to me on WhatsApp or you can email it to us. And I will direct it to Dr. Satyaranjan Das, number one. Number two, if at all you have any queries with regards to the treatment to be taken from Dr. Satyaranjan Das or the cost of the treatment, you can please be in touch with me and I will notify you the cost basis the medical reports that you share with us. I think that's all. And again, thanks a lot, doctor, and thanks a lot all the viewers for your support. You've been really kind and patient watching the webinar now till this moment and till the end. And we are going to we have already recorded the session and we are going to put it on YouTube and I will share the we will share the links to very soon. That's all from us. Thank you from
Thank you very
India.
much. Thank you very
Namaste
much.
to you.
Namaste from my side to everybody. Thank you.
Thank you. Thank you. Sana, you can end the call from here.